everyone. My name is Katie Hettinger, and I am the Flip the Pharmacy Indiana team lead and the assistant network facilitator for CPSN Indiana. Thank you so much for joining us for part two of our opioid podcast series. If you haven't yet, I encourage you to go back and listen to part one of this podcast that covers identifying and acting on opioid use disorder in community pharmacies. For today's podcast, it is my pleasure to welcome back my friend and colleague, Dr. Molly Nichols, to talk about different patient opioid scenarios you might encounter at your pharmacies. Molly is one of our Team Indiana Flip the Pharmacy coaches with Purdue. She just wrapped up a 2-year community practice research fellowship with Dr. Margie Snyder and will start a research assistant professorship with Purdue in January of 2023. She has spent the last 4 years studying opioids, substance use disorders, and harm reduction, and is a certified medication-assisted treatment specialist in Indiana. Molly, thanks for joining us again and sharing your opioid expertise with us.
My pleasure. Thanks for having me back.
Let's jump in and get started. So, pain. It's a complicated topic. When the American Pain Society added pain as the 5th vital sign in the 1990s, and Big Pharma advertised opioids as a non-addictive pain reliever, this started the first wave of the opioid epidemic, if you will. We've recently swung in the other direction with restricting opioid prescribing, which in some situations has caused significant patient distress. I think some pharmacists might feel like they're walking in a minefield when they talk to patients about pain and opioids. Would you agree?
I completely agree. Pain is a super complicated and sensitive subject for many patients. I can remember a conversation I had while I was an API student with a patient about potentially needing to lower his opioid med because of a recent benzo addition to his regimen. All in the name of his safety, of course, but oh boy, was he mad about that. And at the time, I couldn't understand why he had such a strong reaction to something that would make him safer. But now I realize that his anger could have been a reaction to so many different complications if his pain wasn't properly controlled. Uncontrolled pain can severely limit quality of life. What if that patient needed his opioids to be able to walk around his house and take care of himself? I know I would be scared if my freedom to live alone was threatened too. I also think about pain from a health equity perspective now. The patient who I spoke with during my API was Black, and I've since learned that Black and Indigenous people of color are more likely to have their pain underestimated by healthcare professionals. They're less likely in general to receive opioids for pain management at all, and they're more likely to have restricted early refills for opioids and non-cancer pain. So my patient was not only potentially scared of losing his quality of life, he was also carrying all of that mental and emotional weight of potential discrimination during my conversation with him. So of course he was angry. And you know what? Maybe he wasn't even angry. Maybe he was scared and it just sounded like anger on my end. I think too now about social determinants of health and pain. If someone is in too much pain to go to work, then their income is at risk. Their ability to put food on the table for themselves or for their family is at risk. And if they can't work, they probably can't exercise, so perhaps their mental health declines as a result. Pain can just affect so many areas. I would say every area of someone's life. So it might sound dramatic to say that pain control can be life or death, but for some patients, I really think that that's genuinely how they feel about their pain. And I think then as pharmacists, if we approach pain conversations with the mindset that this might feel like life or death for our patients, it's a lot easier to understand why some people might get very angry or upset. And again, trying to navigate that minefield like you referenced. It's also a lot easier to ask the right questions if we apply this health equity and life or death mindset. So for example, you could ask, how does taking this medication, this opioid medication, hydrocodone, Norco, whatever it is, how does taking this opioid benefit your day-to-day life? And this you can ask to try to get an understanding of the importance of that opioid before you jump in and talk about not being able to refill it or needing to reduce the dose and that kind of thing.
I really love that. Thank you for that perspective and those examples. I think another thing is one of those especially tricky conversations is when a patient needs to taper down or taper off their opioid medication. Can you walk us through some of those scenarios and touch on when it's appropriate to use a slow versus maybe a quick taper?
Yes, that's a great question. So there are several reasons why a patient might need to taper down their opioid med, the least complicated of which being that the patient themselves requests a reduction in their dose. Other reasons might be that the patient is experiencing a serious or intolerable side effect. Maybe they have severe constipation or extreme fatigue. Maybe they even had an overdose. You might also want to reduce or stop an opioid if the patient has a concurrent med or health condition that increases their risk of respiratory depression. For example, like benzodiazepine or asthma. Perhaps the patient's mental health is declining. Maybe they're experiencing addiction or substance use disorder, or quite simply, maybe that opioid regimen they're on isn't working. Maybe it's either not controlling their pain or the patient is struggling to stay adherent and not able to get the full benefits of that opioid and they need to try an alternate therapy. If the patient has an intolerable side effect or a medication or health condition that increases the risk of respiratory depression, these are reasons to taper down on their opioid dose. If, on the other hand, there are diversion or substance use disorder concerns, or the opioid is having no effect on their pain, these are reasons to taper completely off of that opioid. And that brings us to the question of whether to use a slow, standard, or fast taper. And quite honestly, there's a lot of variation in what is considered slow or fast. So today I'll walk through the outpatient opioid tapering algorithm that is provided by and referenced from Flip the Pharmacy. So in this algorithm, a standard taper is reducing a patient's total daily opioid dose by 10 to 20% per week. And personally, I would follow that start low, go slow mantra and start out with 10% per week. So here you would calculate what the patient's total daily opioid dose is currently, and then reduce that total daily dose by 10% each week until you reach your desired lower dose or complete discontinuation. And the standard taper is most appropriate to use for patients who've been taking opioids for more than 1 week, but less than a year. There's also a slow taper, and this is reducing a patient's total daily opioid dose by 10% per month. The approach is the same here. You calculate the total daily dose, then reduce the total daily dose by 10% each month until you reach your desired dose. The slow taper is most appropriate for patients who have been taking opioids for more than 1 year, or for patients with cardiorespiratory disease, perhaps patients who have anxiety about the tapering process or just specifically request a slower taper, and also for patients who are psychologically dependent on opioids. And this is not the same as addiction, but rather a mental attachment to their opioid med, which has resulted from medicine reduce their pain and increase their quality of life. It's natural that the patient might have a mental attachment to that medicine. There's also the fast taper, which is immediately reducing the patient's total daily opioid dose by 50%. So on that day one, you have the opioid dose, then reducing by 20% every day until you reach your desired dose. Fast tapers are typically only indicated if patients have been taking opioids for less than 1 week, or in emergency situations, like if your patient experienced an overdose. In that case, you would want to reduce the dose a lot, again, that 50%, and then reassess to see how the patient responds. Again, I will point out that you might have some withdrawal with a faster taper, particularly if the patient's been on opioids for a while. But again, that fast taper, usually the patient has not been on opioids for a long time. Also, you have to consider if the patient is on both a long-acting and a short-acting opioid, you have to choose which one to taper first. So the pros of tapering short-acting opioids first are reduced chances of the patient needing to take more throughout the day and reduced impact of repeated peaking levels throughout the day with those short-term opioids, or short-acting opioids, excuse me. The pros of tapering long-acting opioids first are your patients having a potentially easier time mentally since the long-acting opioids don't have that peak effect, and also maintaining their short-acting opioids for any potential withdrawal or breakthrough pain they experience. You can also potentially customize the long-acting doses throughout the day and reduce the dose during a time where it's not as needed. And I'm probably stating the obvious here, but the tapering process needs to be super individualized to each patient. Some patients will respond really well to decreasing their opioid dose, while others will be highly sensitive. So it's important to check in with your patients often and be less aggressive with the tapering as needed. Again, as I mentioned earlier, you might also want to watch for signs of opioid withdrawal. And we did talk about this briefly in the last episode, but just as a reminder, some of those symptoms might be GI upset, so nausea, cramping, diarrhea, sweating, tearing or runny noses, achy joints, anxiety, restlessness, irritability, or even tremors, perhaps sleep disturbances as well in this case. I'll direct our listeners to part 1 of this opioid podcast series for OTC withdrawal recommendations. But I'll also say that it would be very appropriate to refer patients to their PCPs for withdrawal prescriptions in this case. And just remember that withdrawal can be very, very uncomfortable, and patients may want to pause or altogether stop their tapering. They may also want to stop because their pain isn't as well controlled and they need additional therapy, or they may tell you they want to increase their opioid dose back up. So it's really important to counsel patients on the risk of an opioid overdose if they jump back to their original dose after starting a taper. But all of these scenarios require empathy, motivational interviewing, and reassessment of the patient's tapering goals. And any of these conversations that you have about tapering or recommendations you make to taper should absolutely be documented in an e-care plan and also communicated to the prescriber.
Thank you for that, Molly. I love the reminder to make sure that we continue to collaborate and communicate with other members of a patient's healthcare team. Going off of that, though, can you quickly review for us how MMEs come into play for tapering medications?
Yes, thank you for reminding me. So MME stands for morphine milligram equivalent, and you can calculate a patient's total daily opioid dose using MMEs. So again, going back to that tapering process and saying reduce the total daily dose by 10%, you need to calculate the MME there. So first, you would calculate the total milligrams of each individual opioid a patient receives every day, and then apply the corresponding conversion factor to get the MME for each opioid. Then add up the MMEs for all opioids the patient takes to get their total daily opioid dose. And this sounds very complicated. It kind of is, but the CDC has a mobile app with an MME calculator and their opioid guidelines that I find super useful. It's called the CDC Opioid Guideline app, and it's available on Apple and Android phones. So that should definitely help make the MME conversion and tapering process easier.
On the flip side, can we talk about those other patients who are maybe taking chronic opioids that need to increase their dose to manage new pain? So, like if they have a foot injury or an oral surgery, things that are fairly common. How should pharmacists help support patients in these scenarios?
This is a great question because yes, patients on chronic opioids will still experience situations where they need additional pain relief. So if a patient comes to you with concerns about new onset pain, it's important to first ask questions and assess their pain. So if you recall back to pharmacy school, mnemonics like OPQRST or Socrates, both of those would be helpful here. So for example, with Socrates, where is the site of the pain? That S. When was the onset of the pain? O. Describe the character of the pain, aching or stabbing for the C, etc. You can then recommend pain management based on what the patient tells you after you go through those questions with them. I think it's most important to remember here that opioids are not first-line treatment for pain. So it's more appropriate to recommend ice or heat, rest, physical therapy, NSAIDs, or any other non-opioid analgesics to treat those patients' new onset pain versus immediately jumping to increasing their opioid dose. But if the pain can't be managed by OTC remedies, then pharmacists can support their patients by referring to their PCPs for additional care. And if the patient ultimately does increase their opioid dose for a short period of time, or perhaps that patient's on a long-acting opioid and they get a short-acting opioid added, those patients will likely need support from you, the pharmacist, when they're returning to their original dose. And this goes back to what we were just talked about with tapering. Again, they might experience some withdrawal, or they might just need help in that taper back down process to their original dose.
Okay, and then for our last question to kind of bring us full circle with part 1 of our podcast series on managing opioid use disorder in community pharmacies. So for those patients with opioid use disorder, they can still have situations arise that require pain management. What should be done in those scenarios? For example, when is it appropriate for patients on Suboxone to take short-term opioids, if ever?
This is also a great and really important question, particularly given that up to 75% of patients with opioid use disorder also report having chronic pain. Let me pause and say that again. Up to 75% of patients with opioid use disorder also report chronic pain. So managing pain in opioid use disorders is not a rare occurrence. And managing pain for patients with opioid use disorders is also incredibly complicated because, for one reason, many of these patients have developed tolerance to opioids and they might not even get relief with high opioid doses. So first and foremost, when thinking about managing pain for patients with opioid use disorder, these conversations need to be patient-centered. Again, I'm probably stating the obvious there, but your patient absolutely needs to be involved in conversations about how to best treat their pain versus going around the patient directly to the provider or vice versa. And my guess is that many patients in recovery will likely want to avoid opioids to protect their sobriety. Going back to what we just talked about, again, keep in mind that opioids are not first-line therapy for pain management. So again, ask those Socrates questions and recommend or determine if non-opioid therapies have been tried with any success in these cases. For patients who are on a medication for opioid use disorder, which as a reminder, those are methadone, buprenorphine, or naltrexone, it's also important to consider drug interactions with any OTC analgesics you might recommend. For example, methadone and buprenorphine can both decrease the absorption of acetaminophen and result in a delay from feeling that maximum relief with that medicine. But let's say that non-opioid therapy hasn't been adequate to control pain for patients with OUD. What then? Keep in mind that methadone and buprenorphine are opioid agonists or partial agonists in the case of buprenorphine. So those two medications themselves can also be used to treat pain. Those medications are typically dosed once daily for addiction purposes to treat opioid use disorder, but their analgesic effects only last around 6 to 8 hours. So continuing once daily dosing will not be sufficient for pain management. Patients and providers may want to consider increasing their methadone or buprenorphine dose and or splitting their doses into 3 or 4 times a day to get that adequate around-the-clock pain management. But even that might not be enough to control pain. So going back to the example you gave, Katie, in certain situations, it is appropriate for patients on Suboxone to also have a short-acting opioid on board for a brief period of time. Same goes for methadone. In most cases, methadone and buprenorphine should be continued during the short-term opioid therapy, so I do not recommend stopping either one of those medicines while the patient has a short-term opioid on board. And as I mentioned before, the short-term opioid therapy dose that they do have might be higher than you would typically see because of that patient's tolerance to opioids in general. I would highly recommend dispensing naloxone in these scenarios because these patients are at an increased risk for overdose. Having opioid use disorder puts them at an increased risk. Being on 2 different opioids puts them at an increased risk. So naloxone, naloxone, naloxone here. And if naloxone is too expensive for patients through your pharmacy, then I encourage pharmacists to direct patients towards Overdose Lifeline, which is a local program in Indiana, or your local public health department so your patient can get naloxone free of charge. I would also recommend frequent check-ins with these patients during their short-term opioid therapy. And in fact, I would probably have a conversation with your patient prior to dispensing their opioid at all about how you can best support them in maintaining their recovery. I would be really explicit about that. You could quite literally say, hey, I'll be honest, I don't have a lot of personal experience with this, but I want to support you in your recovery as best I can. What would be helpful for me to do? Or perhaps you'd say, what concerns you? But definitely ask the patient if they have any ideas about how you can support them. Maybe it's a call once a day or once a week while they're on their short-term opioid, call them and say, hey, just checking in. How are you feeling? Perhaps the patient's PCP prescribed 30 Norco tablets, but the patient only feels comfortable taking home 15. Or maybe the patient wants to be sent home with a doTERRA or DisposeRx product to get rid of any extra tablets at home. and again, potentially remove temptation or other things happening there. Or maybe it's something else. Ultimately, just work with your patient to come up with a plan together. But again, I would be really explicit and say, hey, I know that you are in recovery from opioid use disorder, or I know you're in recovery from opioid addiction, and I see that you also have this opioid prescribed to you for pain. What concerns do you have, if any? How can I help you in this, during this time, that kind of thing. I think patients just really appreciate the personal touch and the concern that pharmacists show. So again, it's more about how you're making the patient feel versus the actual words that you're saying. And then just lastly, on a quick note, the situation does become a little more complex for patients who are on naltrexone for OUD and who also need pain management. So naltrexone is an opioid antagonist, so it blocks any and all opioids from binding to opioid receptors. So you can't have naltrexone and an opioid together because the opioid's not going to work. So again, in this case, if opioids are needed to control pain, you've tried your non-opioid analgesics, your non-pharmacological treatments, and none of those are working. If opioids are needed to control pain, that naltrexone will need to be discontinued, and your patient might not want to do that. They might also instead want to consider switching to methadone or buprenorphine to manage their OUD. But again, here they're going to need, depending on which naltrexone product they take, they might need a washout period. But overall, these choices, these considerations, these conversations should all be driven by the patient, and ultimately empowering the patient to make decisions about their health care is the best way that you can support patients in these cases.
Well, this wraps up our opioid podcast series. Thank you so much, Molly, for taking your time to really help answer the questions that the pharmacists on our team have. We're really excited to get out there and make a difference, and all of your advice and expertise is much appreciated. Thanks everybody on the line that's listening, and we hope that you learned something today.
See ya.